Hello, everyone. We're going to wait a few minutes for folks in the waiting room to get in. Thank you all so much for being here. We'll start in a few short minutes. All righty. Thank you everyone for joining today. And thank you for joining us for our final seminar in this year's 2024 series. This presentation is about understanding implementation processes with normalization process theory. This seminar is part of the 2024 UT Health Institute for Implementation Science seminar series, which features lectures with leading implementation science experts. We will be sharing information for our upcoming 2025 seminar series soon, so please keep your eye out for our website for more information on that. We do have a few quick announcements before we get started. This seminar is being recorded, and the recording will be posted on our website after the event. Our microphones are to be muted, so if you do have any questions or comments during the seminar, please enter them into the Q&A box as we will have time for questions after the presentation. After today's seminar, we will be sending out a survey for attendees to receive CHESS and M-CHESS continuing education credits. Thank you so much to the Michael and Susan Dell Center for Healthy Living for sponsoring this year's continuing education credits for our attendees. Now I'm going to turn it over to Dr. Bala to introduce today's speaker. Thank you.
Thank you, Jeanette. Thank you, and it's really my pleasure to introduce Dr. Carl May. Dr. May is a professor of health systems implementation at the London School of Hygiene and Tropical Medicine in the UK. Dr. May is a social scientist who works closely with clinical researchers, and since 1990, his research has focused on developing a rich understanding of implementation processes around new professional roles, complex healthcare interventions, and innovative healthcare technologies. Much of this work has involved ethnographies and other qualitative studies nested in randomized controlled trials. That's really cool. I'm interested in learning more. Dr. May's research includes work leading the project to develop normalization process theory, which helps us to understand the factors that promote and inhibit effective adoption, implementation, and integration of clinical innovations in healthcare. With that, I'll hand it over to you, Dr. May, and really excited to hear from you.
Thank you very much. I'm so delighted to be talking to you all this afternoon. And it's always a privilege to be invited into people's offices and homes on Zoom and to talk about some of my work over the past few years. And I think I need to change my bio so that it doesn't have the number 1990 in it, because I might as well say I've been doing this since dinosaurs ruled the earth. So there we go. So let me find my my slides. Oh, look. Let's hope this is the right presentation. Oh, yes, it is. It's just all in the wrong place. So anyway, there are all kinds of reasons why we take jobs, and I've moved around a little bit. And I sometimes joke that I moved to the London School of Hygiene because I was dissatisfied with the logo of the university that I was working at the time. And I am very glad to work in an organization that really has such a fantastic logo. There we go. So anyway, before I start, I want to acknowledge and give credit to my long-standing friend, also since dinosaurs ruled the earth, Professor Tracy Finch at the University of Northumbria, who has been a partner of mine in the programme of work that leads to what I'm going to be talking about this afternoon. I I think we've worked together since 1998, so literally since dinosaurs ruled the earth. And I want to say a little bit about myself at this stage because uh, I'm a sociologist by training and a medical sociologist by inclination. And at some point, I became an implementation scientist, and I've never been quite clear when that was. Um, but I've always been interested in how different forms of professional practice and new technologies become adopted and are integrated into clinical practice. Like most people, most social scientists, I have a set of applied research questions, but I also have a fundamental research question, which is what are the mechanisms that motivate and shape socio-technical transformations in care? And to sort of address that, I've quite by accident had a series of long-standing research programs, one of which is about telemedicine systems, and another is about the organization and delivery of care at end of life. And that's something I'm going to be reflecting on in the second half of this talk. Okay. So we're going to talk about theory, and that, I don't know how you all feel about theories, but I kind of feel that sometimes we dive into a world of obfuscation and mystery when we start to talk about theory. All I'm going to talk about today, when I talk about a theory, is a rational and replicable explanation for things that happen in the world that are important to us. So we're not going to enter into any kind of phenomenological mysticism. And here's the slide that I should have spoken to just now. So when we're using theory, we're trying to use conceptual tools that help us to make sense of what we're doing, and what's going on around us and what's happening in things that matter to us. And as I've just said, in a way that enables rational and reproducible explanations. We talk a lot about how methods matter and how reproducibility is important in clinical studies or health services research. But we don't often talk about the importance of having reproducible explanations. And to my mind, those are just as important as methods that lead to comparable studies. It matters a great deal to me that we have the tools to make sense of what we discover when we do health services research of different kinds or clinical research of different kinds. So I'm going to be talking about normalization process theory because it's a tool that enables us to produce rational and reproducible explanations for things that matter in implementation research. There are about, I think, well, for reasons I shan't trouble you with, I had to spend a weekend counting NPT studies a few weeks ago, and I think probably there are about 5,000 published protocols and reports of studies, clinical guidelines, survey instruments, the whole caboodle of things that are shaped in one way or another by normalization process theory. And the value of the theory, to my mind, is that it identifies and characterizes and explains those mechanisms that motivate and shape implementation processes. And we'll come to what an implementation process is in a minute. But right now, we're in the kind of realm of the fundamental question that I was asking a few seconds ago about, well, what are those mechanisms that lead to different kinds of socio-technical transformations in health and care? I find it very interesting to think about this. Um, uh, there is a background to what I do, and in 1994, I found myself invited to the University of Kansas for a period, because a friend of mine who was working there knew that I knew how to use video cameras, and thus began a great program of research on telemedicine systems. It turned out that she was quite wrong. I didn't really need to know how to use video cameras, but by the time that they'd paid for my ticket and I'd arrived, it was too late to tell them that. So I just sort of got on with it and learned fast. The beginnings of telemedicine as a field are interesting because they encompass lots of the things that we're concerned with when we're thinking about implementation. So they encompass technical developments, technical advances, changes in the organization and delivery of care, very significant changes in the experience, the lived experience of patients and caregivers, and of course, very significant changes in the way that clinicians work and the ways that services are paid for. And I found myself doing this really interesting body of work in the United Kingdom that constantly raised a question about why it was so difficult for hospitals, particularly, and other healthcare providers to adopt and operationalize telemedicine systems. And I found myself very dissatisfied with the explanations that we were being offered. And so I'm for those of you who are interested, I'm a qualitative researcher. I had my fill of numbers working in the government statistical service in this country in the early 1980s, in where I literally counted sheep for a living for a while, working for the Ministry of Agriculture. But one of the things that I discovered in was how, when I asked clinicians why it was hard for them to mobilize telemedicine systems of different kinds, they also struggled to explain it. And the frameworks that we had available to us were often very complicated and sometimes a little bit postmodern. But they didn't also really tell us very much. And I was interviewing an emergency room clinician about why the telemedicine system that he was using had failed to take off. And he said, well, Carl, he said, the secret is this, he said. The secret is in the name. It's called telemedicine because it doesn't work. If it worked, it would just be called medicine. And I sort of ruminated on that on my journey home after that meeting. And I thought, this is the secret. The secret is not what it takes to adopt something, but the secret is, what does it take for something to become a normal part of life? And so around about then, began to think about, well, what is normalization? What happens to make things normal? How do they disappear from view and just become things that we do. And so that's what we began to focus our explanations on. And that worked well because we had a practical problem, which was to develop a generalizable framework for understanding implementation. We had a fundamental problem, which was about understanding the dynamics of human agency. And we had a method of working, which was theory building rather than ever collecting more and more data. So we sought to focus on explanation rather than data collection, although we actually do a huge amount of data collection. Our program on telemedicine is still continuing in one way or another. But those of you who might be thinking about theory building, I found it an incredibly difficult and demanding and sometimes very arduous task. Although and it is quite a difficult thing to do. And normalization process theory, which is we've been developing now for, I don't know, 25 years, is rather more difficult to create than I thought it would be. I might not have gone into it if I'd realized how difficult it was going to be. So anyway, look, this is an old slide and I should have updated it to change from 1700 to 5000. So I became interested in implementation processes, and it's worth just distinguishing process from science. So implementation science is about methods of translation. And it's very structured, it's disciplined, and it's controlled as a field because it's a methodological field. Implementation processes, as all of you know in your daily lives, are messy. They're really messy. They're non-linear, they're dynamic, they're emergent, and they involve very complex interactions between human and non-human actors and the contexts in which we all work. And one of the things that we had to do, I think, that was very important to us, was to actually define implementation processes as a process. And so we say that an implementation process is what happens when one group of people attempt to translate their strategic intentions into the everyday practices of others. And so we might be looking at people who are managing the introduction of a new electronic health record, or people who are wanting to implement a trial protocol in clinical research, or people who want to change the mode of treatment for people with inflammatory bowel disease. And they want to translate their strategic intentions, which is a better record, a trial that works, and a treatment that everybody can use, into the everyday practices of others who might be other clinicians, other workers, other managers, patients, their families, and other caregivers. And we focus on the essence of implementation, which is, to my mind, collective action and collaborative work. I think it's really important to focus on what people do together, and I think it's very important to focus on what people actually do. So when we use normalization processes, we're oriented to action. and to what people do and to the work that they perform to make things happen. Less interested in people's intentions or their attitudes or feelings, because in a big hospital, when you introduce an electronic health record, really everybody has to do it. The question is, how do they get on with it, and why do different things happen? It's quite exciting to think about these things. Just a little thing, we began publishing at a sort of micro model of what implementation means in a paper in 2006, and then we've built on it. But most recently, we've framed NPT in a different way. We wrote a coding manual for qualitative research, which has been extremely well received, I think. But we did that in a way that rationalized and simplified the theory. We'd actually generated 149 different constructs and concepts to describe implementation phenomena in the course of our work, and that we desperately needed to simplify that for the user and make what our thoughts and theories more accessible to people who are actually in practice. Okay, so how do we conceptualize implementation processes? Well, the delightful Per Nilsson from Linköping in Sweden wrote a really fantastic paper, which has been, I think, cited about 30,000 times now. It's incredibly influential. To think about what sorts of conceptual tools we use to do this. And he kind of points to three important ones. The first is determinant frameworks. So what are the things that we can see or identify that are barriers and enablers that influence implementation outcomes? And then he said, well, that's not quite enough. We need process models that describe the process of translating evidence into practice. And of course, we need theories and implementation theories that provide understanding and explanation of implementation processes. Well, it turns out that normalization process theory performs those three functions. It contains material that acts as a determinant framework. So it specifies activities that act as barriers and enablers and influence outcomes. It provides a process model. So this describes the way that determinants interact with each other to create an implementation process. And it offers a theory. So it offers a set of theoretical propositions that that describe the process. And we now have a fairly substantial body of literature that validates the theory in those ways. So let's go back in time to 2009, and this was our first version of a determinant framework. So we looked at probably 50 or 60 studies that had implementation processes at work with them, and we discovered these sort of core barriers and enablers. I'm not going to trouble you with them too much right now. They're certainly very available in the papers that we've written. But importantly, we also saw that as we created this taxonomy of implementation activities, the work that people are doing to make things happen, we were also describing a much more coherent body of activities. So people perform coherence building work. They make something sensible. They engage in participation work. So they draw themselves and others into practice. They perform collective action, so they make things workable, and they integrate them into practice. And very importantly, they monitor and appraise what's happening while they're doing that work, so that at every stage we're thinking about what has happened as well as what will happen. And these are very powerful forces at work. They're as powerful as the tides when we come to think about implementation processes, how people make sense, how people join in, how people enact, and how people monitor what's going on. And to do this, they invest in meaning and commitment and effort and comprehension. Oh, I'll have to come back to this slide. I put it in the wrong place. So the message there is never fiddle with your slides before your presentation. So we developed a process model that shows how those different things interact in a set of feedback loops and how they're moderated by organizing structures and social norms and group processes and conventions. And this model has stood the test of time. I've been very surprised how little we've changed it over the years. And that might be because the constructs of the theory actually do represent something that is more or less universal. And there are studies now, there's literature from China and India, East and South Africa, South America, North America, and Australasia that kind of uses these constructs and concepts in comparable ways. So we're not over-interpreting our constructs. Okay, so we also say we have an explanatory theory. And this is where the theory is. It's in a set of hypotheses or propositions that become available to us. And that in itself, I think, is a pretty exciting way forward for me. Now, NPT also brings us a framework for investigation. So it predicates a set of relatively simple looking questions and topics that help us to investigate implementation processes. I find this quite important to help us think about what a theory brings us. And I've sort of done it with other people's theories as well, to say, well, what does the framework for investigation for example, the consolidated framework for implementation research bring us? Or what is the framework for investigation that comes from diffusion of innovations theory? Okay, so that's the very abstract business of theorizing. And now I want to look at implementing treatment escalation plans, which are tools that clinicians can use, and they're a very important part of end-of-life care in the United Kingdom. I know that end-of-life care is very different in the United States, but and very different in other countries too. So this is my kind of little tour into the United Kingdom. So several years ago, there was a push from the Department of Health, which is the government department that delivers the National Health Service in the United Kingdom, to find good shared decision-making procedures to identify and enact the preferences of patients and family members around end of life, around times when it might be that the patient doesn't have the capacity to indicate their preferences or choices. So it's a sort of, it's not quite an advanced care plan, but it's a device that enables people to record what they're hoping for at the end of their life, recognizing, of course, that often those choices are taken away from us by pathophysiological deterioration or by the failure of treatment. So what we did was we did a number of NPT-informed literature reviews. We looked at the problem of implementing goals of care plans, and we looked too at how we needed to think about the implementation of advanced care plans. But we did a little bit more than that. We also did a large notes review that helped us understand the trajectory of patients towards death. I'm not going to go into that in any detail because I don't have time, but actually it was that piece of research that really helped us understand what goals of care or treatment escalation plans would give us. So we did that study of patient trajectories, and it helped us to identify pressure points at which goals of care decision making can be really useful and really important. And then we did a huge amount of co-design work and observation and interviews that looked at the practical problems that people experience as they proceed towards death. In the middle of this study, I was taken very seriously ill, and I found myself on the wrong end of a goals of care plan, and that really made me think a great deal about the work that we were doing in a much more user-centered way. Fortunately, I survived, but it did make me think about what is a shared decision-making tool? What does it actually do? And evaluation typically looks at what happens to intervention components. So does a thing work, or does it do what we intended to do? Does it have fidelity? But I also saw some other things going on in that moment about how interactions between people change and the strategies that people use and how those relate to assumed capabilities. And I also looked at and saw how people's delegated accountabilities change in those settings, and how patterns of agreement and value give cognitive authority to people and meaning to their actions. And of course, subsequently, I sort of followed this up empirically and in reviews. So it became important to me to understand what was going on there. And so we can think about the different landscapes through which goals of care plans are operationalized. So advanced care plans give us generalized preferences about our future. Treatment escalation plans are much more specific, but we move from how we hope for the future to what we hope others will do. But finally, we move to patient care in real time and what we hope to actually experience. These are critical kind of problems, but they work across a temporal landscape. They work across time, and the further away from our end we are, the more likely our preferences are to be generalized. And the closer to our end we are, the more we're trying to negotiate around very specific things. And that's an empirical observation from a much longer term piece of work that I've been doing really my whole career since I was a PhD student, that looked at what terminal care means in British hospitals, which is the book I hope to write if I ever get a sabbatical. So the next thing we need to do is to think about the landscapes of accountability. So we have institutional accountabilities where we have trust in systems. We have preferential accountabilities. You know, what are our preferences that give us trust in practices? And we have relational accountabilities that call on trust in persons. So once again, we move from the general through to the very particular around accountability. And these structure decisions, where we are in that landscape structures our decisions. Now, and then of course, we have the question of who is making a shared decision. And again, we get closer to the moment, the critical moment. So we start by having collaborative decisions that are shared. And then we make delegated decisions where people are assigned a role, either as a proxy for decision making, or they usurp that role. We see plenty of cases where people usurp the decision. And finally, there are shaped decisions that happen right at the critical moment when there's lots going on. And the question is not what should we do, but what can we do in this moment? And so again, decision-making processes work across very different relational landscapes. Oops. And then we get into the world of obstacles. So decisions might not be transferable. People, health and care professionals, might refuse to acknowledge or recognize them. Decisions may be not be transportable. They may be lost or forgotten or just unknown. And they may not be negotiable. There's force majeure, the moment at which pathophysiological processes or institutional incivilities overwhelm our preferences and plans. They overwhelm the decisions that we have shared. And then we need to think a little bit, and here we're beginning to head from that sort of open coding world where we're investigating what happens around around shared decision making. We're sort of moving into the world now. Well, what is the work that a shared decision making tool does for us? And perhaps the most important thing is that it converts an implicit or natural status passage into an explicit organizational process. And what comes from that is relational restructuring. So interactions are changed, not just by a decision, but by the work that is available to make that decision. And of course, normative restructuring, how rules and resources for action are changed by a decision. And we can identify the work with this, the work of disclosure, the work of recording, the work of distribution, and the work of accountability that shapes relationships and tasks and negotiations and obligations. And I find this sort of very simple diagram very helpful because it brings into the foreground all of the things that can go wrong when we try to implement a shared decision-making tool. So we come to some risks: risk of disagreement, risk of error, risk of refusal, and risk of inaction. So these are risks that, when we think about the work of shared decision making, these are risks that we need to think about mitigating. And again, how are these things translated into the everyday work of care? Well, we can return to my little diagram about what is a shared decision making tool. And we can see that the kinds of work that I'm talking about in the previous slide actually get turned into work about legitimacy and enrollment. So we need to make this tool a legitimate thing to do. And that's really difficult, actually, for people who are very distressed about the certainty that their own lives are coming to an end, and people who are very distressed at the prospect of someone that they love coming to the end of life. And for staff, for clinical staff around them, there is the need to manage relational risks and systemic risks. So a shared decision making in this area actually becomes something that is about converting individual risk into an organizational process that can be quality assured. So all the time when we're doing this sort of work, or this sort of research, we're fundamentally asking, what is the work that people do? Because this is the thing that normalization process theory is about. It's about how people work to achieve ends. And we can move very swiftly to something that takes us to actual normalization process theory constructs. So we need to create a process that minimizes and mitigates distress. And that meets the NPT construct of interactional workability. We need to create a process that is trusted by participants. And in NPT, we look here for work that creates relational integration. Obviously, we need to create a process that's easily performed. And so we look at the skill set workability of a piece of activity, like a shared decision-making tool at end of life. And of course, we need to secure resources to support operability. Well, what's going on here is that we're converting individual preferences into actionable practices, and we're converting actionable practices into collaborative work. And as we do that, we're interested all the time in how something is going to become routinely incorporated into practice. So what I've tried to do in the past few minutes is, or it may seem like hours, a grim litany of hours or days to some of you, but I've tried to think about how theoretically informed design and development and evaluation are practically useful, and what theory gives us. So this would count for any good theory. It certainly doesn't have to count for normalization process theory. We're interested in giving a rational and empirically informed, supported framework for action. We're interested in explaining why and how and for whom complex interventions work. And we're interested in supporting the transferability and generalization of interventions in practice. And this is why I talked earlier about the importance not simply of reproducible studies that use reproducible methods, but actually the importance of rational and reproducible explanations. So that when we speak about processes, we share a common language, a common vocabulary. I find that that's the thing that interests me very much at the moment about research on implementation processes is how different vocabularies are emerging to describe the same phenomena, and how those vocabularies are often to do with the nature of national healthcare systems, national the ways in which healthcare is provided, and how they are related sometimes to the great problems of access to care that many people have. Okay, I think we are going to repeat all of those things, but I want to talk a little bit about the last one of these. So what theory informed investigation and design is useful for is because it actually tells us about the strategies for successful implementation, and that's something that I've been getting at in my case study. Strategies for successful implementation actually rely on people understanding in some depth the implications of the work that they do. And treatment escalation plans at end of life are a great example of that, because they are so critically important and often quite dramatic. So I should, at this stage, coming to a conclusion, but I must acknowledge the funders for this work, who have been hugely supportive, and my many co-authors and collaborators. And there are probably, I don't know how many people have actually co-authored and collaborated on the work that I'm describing, but it's certainly more than 100 and spread across many countries. I always say thank you to Victor Montori at the Mayo Clinic, who was an early subscriber to NPT, and to Jane Gunn at Melbourne in Australia, who was also an early subscriber, and the very wonderful Bill Maton-Howarth, who was the Principal Public Health Research Officer at the UK Department of Health in London. And I always say thank you. It's always a privilege to talk. And if you want to follow up anything that I've said, I don't know whether I can say follow me on Twitter anymore. It's all become so dreadful. But you can follow me on Blue Sky if that's an area that you're interested in, or just email me at carlmay.at.lshtm.ac.uk. Thank you very much for your kind attention.
Thank you, Dr. May. Really, really thought-provoking conversation and presentation. I'm looking for some Q&As, and people might still be mulling over everything you said. And well, Maria's here, so we'll say hello. Maria, do you want to? I know you are traveling and at a conference.
Yes, and sorry about the purple color. I don't know where that's coming from. That's funny. But thank you so much. Just outstanding presentation. I was wondering, in one of your slides, you said that normalization process theory is a middle range theory. Can you say a little bit more about what you mean by that?
I can. What I mean by that is it's concerned only with what it's concerned with. So I know that's not a very helpful definition. So it is concerned only with implementation processes. It's not a general theory of work, in fact, and it's certainly not a general theory of organization, but it helps us understand a limited set of phenomena. And those are the things that people need to do to successfully implement some practice, some evidence-based practice. There is a tendency in theory building in the social sciences to gradually extend and expand the topical area of a theory. And a really great example of that is the theory of planned behavior, which when I was a baby postdoc was something that we used to explore the way in which people might want to stop using illicit drugs or alcohol or tobacco, but which gradually over a period of about 15 years came to be extended to almost every facet of human behavior, to the great detriment of the theory itself, I think. So I guess I'm pushing for modesty and humility around the focus of conceptual models of all kinds. And when we think about a sort of a limited scope for the theory, we're going back to the really wonderful Robert K. Merton and his sociology in the 1950s around what is sociological theory for. Of course, NPT isn't really a sociological theory anymore because my great collaborator, Tracy Finch, is a social psychologist. I think she would say, well, it's full of things about social psychology, and she's right. I don't know, Maria, have I answered that question to your satisfaction?
Yes, absolutely, you have. And Vigil, I'm going to let you read that one of the questions that came up in the question and answer
Yes.
group, if you can. I think it's great.
Yeah, thanks, Maria. It really thought-provoking, provocative, probably even the question. I mean, this person is saying, well, much in the way that I don't need to understand, for example, the proof of a ball's projectile motion in order to situate myself in space to actually catch the ball. Like, I don't need to understand that. And so I think they're saying I'm dubious of the need to understand the precise mechanisms behind implementation processes in order to affect the behaviors that move these processes forward. For example, effective team communication, applying active listening skills, so on and so forth. And they don't ask a question, but I think they're raising the need to understand all these specific mechanisms that you talked about behind implementation processes. I wondered if you wanted to comment on that, Dr. May.
Well, I mean, that's a fantastic question, isn't it? But so do we need to understand the forces that propel a ball through space and how we might catch it? Of course we do. Otherwise, we're not going to be able to catch the ball. The issue is that our calculations and our understanding of motion is so deeply embedded in our cognitive sort of process that we catch the ball in a way that seems instinctive and without thought, unless of course we're playing football or baseball or something like that, where you're performing quite complicated calculations about where the ball is going to end up. So the question is, how much do we need to know about an implementation process? We actually need to know a bit. And one of the things about building conceptual models is that we constantly discover the things that we didn't include that matter. So yeah, you might not need to know very much. And a lot of what you know is implicit or tacit. But you do need to know something, and that's why we kind of compress NPT into four main constructs. What do we do to build coherence and understanding? What do we do to participate? What do we do to act? And what do we do to monitor? And those four things, I think, are all have the appearance of relative simplicity, but actually require some serious interrogation. So we know that things have to make sense to people. We know that people have to want to participate and believe that something is a legitimate thing to do. And we know that they have to be able to do it and make sense of it after the fact. But when we want to understand the reasons for failed implementation, we have to dig a little deeper. I think that would be my answer. I think it's a fantastic question. I like the sporting analogy, and I'm going to relentlessly plagiarize that. I don't know the identity of my interlocutor, but it's whoever you are, thank you.
Thank you. And I think there's some follow-ups from that, perhaps from the same person or not. But I think I would summarize it to say, if you can comment on sort of this challenge of the academic exercise and academic focus of theory building and its application in practice. I think there's this tension of how the MPT process, implementation process, and the domains, how might they be used more effectively in practice? And I had a question sort of related, but also how might they be used by researchers to do this practice work, which I'll talk about that later. But I think the crux of what this person is getting at is it feels very academic, it feels very detailed. How do you use that in practice? I think that's kind of where it's coming from. And if you could comment.
I think, again, a great question. We use it in practice by translating it on the spot to practitioners. So the thing that the very first people who came to talk to me about NPT and how it might change practice were not the people that I had ever expected to come. I found myself talking to a group of naval officers about launch procedures for Tomahawk cruise missiles. And if there's an area that is about practice, that would be it. And subsequently, I've worked with, and many of my colleagues have worked with all kinds of healthcare provider organizations to sort of apply this stuff in practice, which is a tremendous discipline, but it's also one of the sources of the need to get more detailed understanding of what we're engaging with, that I mentioned in response to the previous question, that when we do this sort of work, and it is academic, I make no apology for it, this is science, and there's it's science in the same way that lots of other things that we do are actually quite complicated and difficult and all of the other stuff. And so I don't apologize for that. This sort of stuff works when you work with people who are trying to implement something. Otherwise, it is a bit dry and dusty. So that's kind of my view, that there is, when we think about late stage translation, we need to think about what the work that we do is to do that. But one of the things that I would say, one of the reasons that this sort of thing I think is important, is the huge amount of time and money that is wasted on failed implementation projects. Huge amount of and to waste that time and waste that money is to disrespect all of the people who are trying to make something happen. That's my That's my view. It sounded a bit more like a sermon than an answer, but that's where I stand on it.
Yeah, no, thank you for that, and for a really rich discussion. And thank you for the questions. We'll share the rest of the questions with you, Dr. May, and if you feel inclined and have the time, please feel free to respond. And on that note, we will end right at the top of the hour. Thank you so much for taking the time, and thanks everyone for attending. Maria, do you want to say any last words?
No, just to thank you, Dr. May. Outstanding discussion as well. Thank you so much.
Well, thank you for the invitation, and I'm sorry we couldn't meet on Monday for dinner in London, but there will be another time, I hope.
Next time.
So, yeah, thanks very much. Always a privilege to visit and talk, even
Thank you.
electronically.
Take care, everyone.
Okay,
Bye,
bye-bye.
everybody.
Bye.
Thank you.